Imagine stepping into A&E, a new patient on the trolley, and all you've got is that first radiograph. In that silent language, those shades of gray etched across the film, lies the complete story of a patient's musculoskeletal health. For us as orthopedic professionals, deciphering that language isn't just a skill, it's really an art. Today, we're embarking on a deep dive into the foundational yet ever-evolving world of musculoskeletal radiology, our mission. To sharpen your diagnostic eye, to unveil the critical insights hiding within those, let's say, simple plain films, because they truly are the bedrock of our clinical decisions. We are exceptionally fortunate to be joined today. Our expert guest is here to guide us through the nuances of interpreting radiographs, from the basics, say, spotting a subtle fracture, right through to discerning complex pathologies and, crucially, evaluating outcomes after surgery. Prepare yourself for a masterclass in clinical vision.
Thank you. It's a real pleasure to be here to discuss something so fundamental to our daily work. Radiography, as you've rightly put it, is indeed that first line, and really understanding it properly isn't just helpful, is it? It's absolutely non-negotiable for any clinician involved in musculoskeletal care. It's usually where the diagnostic journey begins.
And that starting point, that first line, brings us right to our first big question. Despite the incredible leaps in advanced imaging CT, MRI, they're commonplace now. Why does conventional plain film radiography remain our most commonly used modality for the skeletal system? What keeps it as our first port of call, even now?
That's a pivotal question, actually. And it really speaks to the enduring utility of plain radiography. Well, CT and MRI offer, phenomenal detail. Plain films have several key advantages that make them pretty much indispensable. Firstly, there's the accessibility and the cost-effectiveness. You can get a plain film almost anywhere, can't you? A busy AD, a remote clinic, at a fraction of the cost of a cross-sectional scan.
Right, availability is key.
And secondly, the speed. Speed of acquisition is just crucial. In a trauma setting, seconds count. You get immediate diagnostic information from an X-ray to quickly rule in or rule out major pathology. And that informs urgent decisions about management or, whether you even need more advanced imaging.
So it helps triage resources effectively.
Precisely. It makes it the ideal initial evaluation tool across a really wide spectrum of health professions. GPs, orthopedic surgeons, chiropractors, osteopaths, physios, podiatrists. It's the essential screening tool that lets us allocate those more complex, expensive resources appropriately. It's truly the workhorse of musculoskeletal imaging.
The workhorse indeed. Love that term. And when we're looking at these images, these shades of gray, it's all about understanding what we're actually seeing. Could you break down those fundamental principles of X-ray projection for us? How do different tissues show up, and why is really grasping this spectrum of gray, this radiodensity, so vital for accurate interpretation?
Right. It all boils down to the basic physics of how X-rays interact with matter. X-ray projection is fundamentally dependent on the thickness and density of the tissue the beam has to penetrate. Think of it like shining a very bright light through different materials. The denser or thicker the material, the more light it blocks, right? Yeah. So less light reaches the screen behind it. With X-rays, the less penetration, the wider the image appears on the film or the detector.
Okay, so more blockage equals wider image.
Exactly. So at one end, if there's no tissue like air in the lungs or just around the soft tissues the X-rays pass straight through, that results in a completely black area on the image. Then you have soft tissues. They're denser than air, but much less dense than bone, so they appear as various shades of gray. Muscles, fat, organs, they'll all have slightly different gray tones depending on their specific densities.
Subtleties within the gray.
Yes. And fluids, say synovial fluid in a joint effusion, they generally appear as a lighter gray than the surrounding soft tissues, indicating a slightly higher density. Then we get to bone. High calcium content, significantly denser than soft tissue, absorbs many more X-rays, so it appears as an even lighter gray, often bordering on white.
Almost white, okay.
And finally, metal. Think orthopedic implants. That's the densest material we commonly see. It almost completely blocks the X-rays, so it appears as a bright, stark white. Understanding this precise gradient black for air through the grays to bright white for metal is critical, because any deviation from these expected shades can immediately flag up a pathological change.
Like a fracture line or a tumor?
Precisely. Or infection, or changes in bone density. It's our fundamental visual guide.
That's a fantastic breakdown. So just thinking about that, a miscalibrated machine, perhaps overexposed, could that theoretically make a perfectly healthy bone look, osteopenic, just by washing out the grays? That sounds like a critical technical pitfall.
You've hit on a crucial point there. Absolutely. Overexposure can artificially increase radiolucency, making normal bones seem less dense. And conversely, underexposure can make it seem artificially more dense, potentially hiding osteopenia.
Right.
This is exactly why good radiographic technique and consistent image quality are paramount. And of course, why we always correlate the image with the patient's clinical presentation, age, and build. You can't interpret in a vacuum.
Never in the vacuum.
Okay.
So we've got the picture of what we're looking for in those shades, but before we even get to interpretation, what are the absolute ground rules for getting the images in the first place to ensure we actually have a meaningful picture? I'm thinking specifically about that vital rule of two in radiography. What does that encompass?
Ah, the rule of two, yes. A cornerstone for avoiding diagnostic blind spots. It's not just a guideline. It's really a fundamental principle, especially in trauma. It covers 4 key aspects. Firstly, 2 views. It is absolutely essential to get at least 2 views, usually an AP and a lateral, taken at 90 degrees to each other.
Why is that so critical?
Because a single view can be incredibly deceptive. A fracture might be entirely invisible in one plane. Or its true extent, its angulation, its displacement, that can only be fully appreciated when you see it from 2 orthogonal angles. Imagine a simple transverse fracture on the AP. It looks okay, but the lateral might show significant angulation. Failing to get 2 views is a classic cause of missed fractures, a preventable error.
Okay, 2 views. What's next?
Secondly, 2 joints. It's imperative to include the 2 adjacent joints, the joint proximal and the joint distal to the suspected injury.
Right, the joints above and below.
Exactly. The rationale is simple. Reduce the risk of overlooking a related fracture, subluxation, or dislocation that might occur at a site distant from where the patient is pointing. Think about a mid-shaft forearm fracture. You must include both the elbow and the wrist. Why? Because of things like Monteggia fractures, proximal ulna break with a radial head dislocation.
Or Galeazzi, the radioshaft fracture with the DRUJ disruption at the wrist.
Precisely. You'd miss this entirely if you only x-rayed the forearm shaft.
Got it. 2 views, 2 joints. What else?
Thirdly, 2 sides. This rule applies particularly to the immature skeleton children and adolescents. Growing bones have physes, growth plates.
Those radiolucent lines that can look like fractures?
Exactly. They can be very easily mistaken for a fracture, especially by someone less experienced. So, to confidently differentiate a normal growth plate from a true physeal injury, it's often critical to get a radiograph of the normal, unaffected contralateral limb for comparison. That side-by-side view reveals the typical appearance for that specific child at that specific age, preventing misdiagnosis.
Makes sense. Comparison is key in PAIDS. And the last 2.
And finally, 2 occasions. This is a specific but critically important nuance, particularly for certain subtle injuries like, classically, scaphoid fractures in the wrist. Initial radiographs can be deceptively normal, perhaps in up to 25% of scaphoid fractures.
Even when the fracture is definitely there.
Yes, due to the bone's complex shape and the often hairline nature of the break. So if your clinical suspicion remains high despite negative initial films say, the patient has definite tenderness in the anatomical snuff box. The standard protocol is to immobilize the wrist anyway.
And bring them back.
Exactly. Bring them back for follow-up radiographs after 1 to 2 weeks. By then, the body's natural healing response, specifically bone resorption at the fracture site, often makes the fracture line visible. It's a classic example of trusting your clinical judgment and knowing the limitations of that first image.
That's incredibly thorough. It really highlights how much thought goes into just requesting the X-ray. It's not just take a picture, it's asking the right questions with the picture. But what about when even standard AP and lateral views, following all those rules, just aren't enough? When do we need oblique or special views? And for which parts of the body?
You're spot on. Standard views are the foundation. But for certain complex anatomical areas, they might not give us enough clarity to solve the puzzle. That's when we reach for oblique and special views. For instance, the elbow. Oblique views can be invaluable for seeing subtle radial head or coronoid process fractures that might be hidden by overlapping bone on standard views.
Okay. Elbows are tricky.
Very. The knee often benefits from weight-bearing views to properly assess joint space narrowing under load, much more revealing than a non-weight-bearing view for osteoarthritis. And specific obliques can delineate complex tibial plateau fractures better. The wrist, well, it's notoriously intricate. Beyond AP and lateral, the specific scaphoid view with ulnar deviation is absolutely critical.
Right, to elongate the scaphoid.
Exactly. For the ankle, a mortise view, usually AP with about 15-20 degrees internal rotation, is essential to properly evaluate the whole ankle joint space, the talar dome, and crucially, the tibiofibular syndesmosis, to make sure there's no subtle widening.
And the pelvis in trauma.
Ah, yes, the pelvis, especially in high-energy trauma.
Uh-huh.
The standard AP is just the start. We rely heavily on Judith views, the iliac oblique and obturator oblique views. They let us visualize the anterior and posterior columns of the acetabulum, which are often obscured on the AP, vital for surgical planning. And then you have the specific inlet and outlet views for assessing pelvic ring disruption, rotation, and vertical shear.
So these supplementary views give us that extra diagnostic edge in complex areas.
Precisely. They provide the competitive advantage needed for accurate diagnosis in these challenging spots.
This sounds like a really structured way to avoid missing things, almost a radiographic detective's checklist. Which brings us neatly to the systematic approach for actually reviewing the films, the ABCDE method. Can you walk us through each component? Why is it so vital for preventing diagnostic omissions, especially under pressure?
Absolutely. The ABCDE method isn't just a handy mnemonic, it's a cognitive scaffold, a systematic, sequential framework designed to minimize the risk of overlooking critical findings, even when you're busy. It ensures a thorough review. A is for anatomy and alignment. First step, confirm you're looking at the right patient, the right side, the right projection. Be intimately familiar with the normal anatomy for that view, including common anatomical variants like accessory ossicles, so you don't mistake normal for abnormal.
Know your normal first.
Essential.
Hmm.
Then assess the overall alignment.
Yeah.
Are the bones in their correct relationships, any dislocations complete displacement, or subluxations partial displacement? Spotting malalignment early is crucial. It dictates a different pathway.
Okay, A, anatomy, alignment. What's B?
B is for bone.
Yeah.
This is often the main event for musculoskeletal films, especially in trauma. Here, you meticulously assess the bone itself. The key is to trace along the entire length of every bone's cortex, the outer hard layer.
Follow the white line.
Exactly. Look for any interruptions, breaks, buckling, or subtle changes in contour. Even without a clear cortical break, subtle lines within the bone or changes in the trabecular pattern can indicate a fracture. You're tracing every outline.
Got it. C.
C is for cartilage. Now, cartilage itself is radiolucent. We don't see it directly on X-ray, but we assess its integrity indirectly by examining the joint spaces.
Looking for narrowing.
Yes, looking for abnormal findings like loss of joint space, which suggests cartilage thinning, say in osteoarthritis, or erosions, little scooped out areas, which might point towards inflammatory arthritis. And in children, C is also critical for checking the growth cartilages, the physes, differentiating them from fractures and assessing if the ossification centers are appropriate for the child's age.
Right. Crucial in patagen. D.
D is for deformity and density. Two parts here. First is the bone's proper shape preserved. Deformities can be obvious, like a displaced fracture, or more subtle, like bowing and rickets or expansion from a bone tumor. Second, assess bone density. Is it generally normal, decreased osteopenic, or increased sclerotic? Compare the bone to itself or to adjacent bones. Look for localized changes, little lesions, holes, or sclerotic lesions, bent patches, or widespread changes suggesting metabolic disease.
Okay. And finally, E.
E is for everything else, the vital final sweep. Broaden your focus. Meticulously review all the other elements, especially the surrounding soft tissues.
What might we see there?
Things like soft tissue swelling, indicating edema or hematoma, obliteration of fat pads, like around the elbow, a key sign of an occult fracture. Look for lipohemarthrosis, that fat fluid level in a joint, pathognomonic for an intra-articular fracture where marrow fat has leaked into the joint, or even subcutaneous emphysema air in the tissues, maybe from an open fracture. It's about checking those subtle, indirect clues.
This systematic approach sounds like it completely removes the guesswork, doesn't it? Instills a methodical discipline. Just a quick thought, how much difference does sticking to this rigidly actually make in a busy A&E setting in terms of catching those tricky don't miss injuries?
Oh, it's transformative,
Yeah.
honestly. In busy settings where you're juggling multiple patients, a systematic approach like ABCDE standardizes the process. It's a powerful cognitive checklist. It actively forces you to consciously evaluate every relevant aspect. This discipline significantly reduces the chance of, well, what we call satisfaction of search errors.
Where you find one obvious thing and stop looking.
Exactly. You spot the obvious distal radius fracture but miss the subtle scaphoid fracture or the associated DRUJ injury. ABCDE drastically improves diagnostic accuracy, especially in complex trauma. It turns every clinician, regardless of experience level, into a more meticulous detective.
Right. From that blueprint of interpretation, let's move squarely into the urgent narratives that radiographs tell everyday traumatic injuries. Because spotting a line is one thing, but truly speaking, the language of that fracture for the rest of the team, the surgeons, that's another level entirely. Once you suspect a fracture, What key aspects must be included in a full radiographic report to give a complete and crucially actionable clinical picture?
You've hit the nail on the head. The report must be actionable. It's the primary communication tool, isn't it?
Yeah.
Between the person reading the film and the orthopedic team. So it needs several critical components to fully characterize the injury. Firstly, the precise anatomic site and extent. Which bone, where exactly diaphysis, metaphysis, epiphysis, intra-articular or extra-articular.
Location, location, location.
Absolutely. Secondly, the type of fracture. Is it incomplete green stick, torus, or complete? What's its geometry, transverse, oblique, spiral? Is it comminuted multiple fragments or segmented? Thirdly, the alignment of the fragments. This is absolutely vital for surgical planning we need to describe. Displacement. How far have the fragments shifted? Often described in millimeters or as a percentage of the shaft width. Angulation. The angle between the fragments, valgus, varus, anterior, posterior, rotation, any twisting. Often hard to judge perfectly on plain films, but critical functionally. Foreshortening. Overlap making the bone look shorter. Or distraction. Fragments pulled apart.
That alignment description sounds key.
It is. Fourthly, the direction of the fracture line relative to the bone's axis. Fifthly, the essential features. Is there impaction fragments driven into each other? Common in cancellous bone. Depression of joint surface pushed inwards, like in tibial plateau fractures, or a compression vertebral body height loss. Sixthly, any accompanying abnormalities. Is there a simultaneous dislocation or diastasis widening of a normally stable joint like the ankle syndesmosis?
Don't miss the associated injuries.
Never. And finally, any unique sorts of fractures. Is it a stress fracture, or does it look like a pathologic fracture through abnormal bone? A comprehensive report covers all these bases.
That's an exhaustive list. Gives a real sense of the information density required. It's almost like writing a diagnostic novel for each fracture. Before we even get to that level of detail, what are some of the early, often subtle signs that should make us suspicious of a fracture, even if a clear break isn't jumping out at us? Those soft signs.
Excellent point. Many fractures are initially subtle, especially in the first few hours. Often it's the indirect signs that act as our early warning system. We look meticulously for soft tissue swelling, one of the most common signs, indicates edema or hemorrhage. Might just look like fuzzy, indistinct soft tissue planes.
Just general puffiness.
Yes. Then, the obliteration or displacement of fat stripes or pads. Classically, the anterior and posterior fat pads around the elbow. If they're displaced, even if the bone looks okay, it's a very sensitive sign for an occult intra-articular elbow fracture.
The sail sign.
That's the one, the anterior fat pad looking like a sail. And the posterior fat pad shouldn't normally be visible at all on a true lateral view taken at 90 degrees flexion. If you see it, there's an effusion. Which brings us to joint effusion itself, or fluid in the joint, especially an intracapsular fat fluid level lipohemarthrosis. That's a dead giveaway for an intra-articular fracture. It means marrow fat and blood have leaked into the joint. You see that horizontal line on a cross-table view?
Pathognomonic, right?
Pretty much. Other subtle signs include a double cortical line, suggesting impaction, buckling of the cortex, that subtle wrinkle in the bone surface, seen in torus fractures in children, and irregular metaphyseal corners in kids, which can hint at a Salter-Harris type 2 injury. These soft signs are crucial. They demand a higher index of suspicion, maybe prompt further views, or at least ensure close clinical follow-up, even if the initial x-ray seems relatively normal.
So recognizing these subtle clues before the overt signs appear is absolutely critical for early intervention. When it comes to actually reporting a fracture, building on those elements, how should we structure that report for maximum clarity and impact? Especially thinking about growth plate involvement in children, which has such distinct implications.
Right, structure is key for clarity. We typically follow a logical sequence. Start with the side, left, right, and the precise site, for example, right distal radial metaphysis. Then, the extent, complete and complete. Next, describe the type, transverse, spiral, comminuted, open, closed, stable, unsettling. Followed by the direction of the fracture line. Then comes that detailed description of the alignment, displacement, angulation, rotation, shortening, distraction.
All the positional information.
Yes. Then explicitly note the presence of impaction, depression, or compression, if applicable. Mention any associated abnormalities, dislocation, diastasis, it's critical for management. State if it's a special type stress. Pathologic as that, changes the whole context. And for pediatric patients, it is absolutely paramount to indicate if the growth plate is involved, and if so, to classify it meticulously using the Salter-Harris classification, types IV.
Because the prognosis varies hugely with the Salter-Harris type.
Enormously. A type I has a good prognosis for growth generally, whereas a type B crush injury has a very high risk of premature physical closure, and subsequent deformity. So that classification guides treatment and parental counseling. This structured approach ensures all the vital information is conveyed concisely, accurately, and in a clinically relevant way for the treating team.
Okay, so we've diagnosed the injury in detail. Now our focus shifts to the dynamic process of healing. What factors actually influence how well or how quickly a fracture heals? And how do we track this process or spot complications radiographically?
Fracture healing is a complex biological cascade, true, and its success depends on a whole host of factors. Patients' age is a big one. Kids heal much faster and remodel better than the elderly. The site and type of fracture matter. A simple transverse fracture heals differently to a highly comminuted one or an intra-articular one.
Location matters again.
It does. The degree of comminution and the initial fragment position or gap are key. Blood supply to the fracture site is absolutely paramount. Some areas, like the scaphoid waist or the femoral head after a displaced neck fracture, have a notoriously precarious blood supply, increasing the risk of non-union or vascular necrosis. The quality of immobilization or fixation is fundamental stability promotes healing. And finally, any accompanying factors like infection, chronic illness, diabetes, smoking, nutritional status, or the development of osteonecrosis can severely impede healing.
So lots of variables. How do we monitor healing on X-ray?
Radiographically, we monitor the progressive formation of callus, that's the new bone forming around and bridging the fracture site. We look for its density, its organization, and whether it clearly bridges the fracture gap. We also track the gradual obliteration of the fracture line itself, and over the longer term, the remodeling of that callus back towards the original shape of the bone.
And how does this callus formation differ between what we call primary versus secondary union? They sound quite distinct processes.
They are indeed quite distinct healing mechanisms. Primary union, sometimes called direct bone healing, occurs under conditions of absolute stability. Think undisplaced fractures, or fractures that are perfectly anatomically reduced and held rigidly with compression, often using plates and screws. In these cases, there's minimal gap, minimal movement. The fracture line is directly obliterated by internal or endosteal callus, essentially bone growing directly across the gap. You see very little, if any, visible external callus on the X-ray. It's a more direct bone-to-bone healing.
So minimal external signs on the film.
Correct. Secondary union, on the other hand, is the more common pathway, especially for fractures treated non-operatively, or with less rigid fixation like intramedullary nails or external fixators, where there's some controlled micromotion. This involves a much more robust and radiographically visible periostele, or external callus formation. This callus goes through distinct biological stages: hematoma, granulation tissue, fibrous tissue, fibrocartilage.
The body builds a scaffold first.
Exactly. That fibrocartilage provides early stability. Then it ossifies into woven bone, which is initially quite disorganized. Finally, this woven bone remodels over months or years into strong, organized lamellar bone. Radiographically, we see this progressive ossification of the external callus. Bridging the fracture gap is the key sign of a successful secondary union.
So the radiologist isn't just looking for callus, but assessing its quality, location, and how it's maturing over time. What are the radiographic signs of healing going wrong? What complications should clinicians be watching for on follow-up films? What screams trouble?
Precisely. We're looking for deviations from that expected healing timeline and pattern. The main complications we identify radiographically are delayed union. This means the fracture is taking significantly longer than expected to heal for that particular bone and patient age, but it is still showing some signs of progression. You might see some callus, but it's slow to form, maybe not bridging the gap yet, and the fracture line is still quite visible. It's healing, just slowly.
Still hope, but slow progress.
Yes. Then there's non-union. This is the complete cessation of the healing process. The bone has failed to unite and, crucially, shows no further signs of progression over several months. Radiographically, this is characterized by the persistence of a clear fracture line, often with sclerosis, increased density and rounding, of the bone ends facing the gap. There's a complete absence of bridging callus across the fracture gap. Sometimes you even see the ends becoming smooth and forming a pseudoarthrosis, a false joint. A classic example is non-union of the shaft of the humerus. You see that persistent gap, sclerotic ends, no bridging bone. It needs intervention.
Okay, failure to heal. What's the third one?
And finally, malunion. This is where the fracture is healed, but the fragments have united in an unacceptable anatomical position.
Healed, but crooked.
Essentially, yes. This could involve significant residual angulation, rotation, shortening, or displacement. This can severely impact function, cause pain, lead to abnormal joint loading, and secondary arthritis down the line. Malunions often require corrective osteotomy surgery. Hashtag 2.3 regional trauma highlights.
Right, let's quickly navigate some common traumatic injuries across the body, pinpointing their distinctive radiographic features. Let's start with the upper extremity. What are the key points for shoulder dislocation, those common proximal humerus fractures, and perhaps touch on those complex forearm fracture dislocations like Monteggia and Galeazzi, often cited as don't miss injuries?
Okay, starting with the shoulder. It's crucial to remember it's the most commonly dislocated major joint, up to 45% of all dislocations, and the vast majority, around 96%, are anterior dislocations. Radiographically, in an anterior dislocation, the humeral head is clearly displaced from the glenoid cavity. It typically lies anterior and inferior to the glenoid, often beneath the coracoid process. It looks like it's hanging off the front, usually clear on AP and axillary lateral views.
Anterior is the commonest. What about proximal humerus fractures?
Proximal humerus fractures are very prevalent, especially in older adults. They account for about 4 or 5% of all fractures. We often classify them using near system based on the number of displaced major fragments or parts of the head, greater tuberosity, lesser tuberosity, and surgical neck. So you can have one part essentially undisplaced, two-part, three-part, or four-part fractures, as well as fracture dislocations. The number of displaced parts significantly guides treatment, from a sling for stable one-part fractures to complex ORIF or even arthroplasty for severe four-part injuries.
Okay, and those tricky forearm ones, Monteggia and Galeazzi.
Ah, yes, the name's forearm fracture dislocations. Always be vigilant. A Monteggia fracture dislocation is defined by a fracture of the proximal ulna shaft, coupled with a dislocation of the radial head at the elbow. Remember, Badow's classification helps type them based on the radial head dislocation direction. The critical radiographic pearl: always draw a line through the center of the radial neck and head on both AP and lateral elbow views. That line must point directly at the capitellum in all views. If it doesn't, the radial head is dislocated, even if the ulna fracture looks minor. Missing this is a disaster.
The radiocapitellar line. Crucial.
Absolutely. A Galeazzi fracture dislocation is the counterpart. A fracture of the radial diaphysis, typically middle to distal third, associated with disruption or dislocation of the distal radial nares joint, DRUJ, at the wrist. It's often called the fracture of necessity because it almost always needs operative fixation of the radius to restore DRUJ stability. Radiographic signs of DRU injury include widening of the DRUJ space on the AP wrist view, dorsal or volar subluxation of the ulna relative to the radius on the lateral view, or significant radial shortening, usually 5 mm. Always scrutinize the DRUJ if you see a radial shaft fracture.
Okay, and a quick but vital one for the wrist, the scaphoid fracture. Why is that one so notoriously tricky on initial films, and what's the big clinical implication of that subtlety?
The scaphoid fracture. Yes, it's unique and, frankly, often frustrating. Up to 25% can be invisible on initial x-rays.
Why so elusive?
Several reasons. Its complex, curved shape, the fracture lines are often non-displaced and hairline thin, and overlying bones can obscure it. The clinical implication is huge, though. If you miss a scaphoid fracture, especially at the waist or proximal pole, the risk of non-union and avascular necrosis, AVN, of the proximal fragment is very high due to its tenuous retrograde blood supply.
Leading to significant long-term problems.
Exactly. Chronic pain, stiffness, arthritis, scaphoid non-union advanced collapse, or SNAC wrist. That's why, if clinical suspicion remains high despite negative initial films, definite snuff box tenderness, pain on axial thumb compression, the standard of care, is mobilization in a thumb spica, cast and repeat radiographs, often including specific scaphoid views, in 10-14 days. That delay allows bone resorption at the fracture edges, making the line more apparent. Clinical suspicion trumps the initial negative film here.
A classic case. Moving down to the lower extremity now. What are some critical views and findings for hip dislocation, femoral neck fractures, those scary knee dislocations, and complex ankle injuries involving the syndesmosis?
Right, lower limb trauma. For hip dislocations, second most common after the shoulder, identifying the type is key. Posterior dislocations are commonest. On the AP view, the affected femoral head often looks smaller and lies superior and posterior to the acetabulum. Shetton's line is usually broken. The limb is typically adducted and internally rotated. Anterior dislocations are rarer. The femoral head appears larger, lies anteriorly, often over the obturator foramen or pubic ramus. The limb is abducted and externally rotated. Shetton's line is also broken. The crucial point before any reduction attempt: get good quality films, including a lateral, to definitively rule out an associated femoral neck fracture. Reducing a hip with an unrecognized neck fracture can be catastrophic, leading to AVN.
Always check the neck first. Got it. Femoral neck fractures themselves.
Fracture neck of femur. a huge topic, especially in the elderly population. Bimodal incidence, high energy in young, low energy, falls in elderly. The Garden classification types 1 to 6-OR is vital for guiding treatment. Type Y is incomplete or valgus impacted, stable. Type 2 is complete but undisplaced. Type 3 is complete with partial displacement, varus tilt. Type 4 is completely displaced with loss of continuity between the head and neck trabeculae. Treatment ranges from internal fixation, screws or sliding hip screw, for types 3 in younger patients with 3, to hemiarthroplasty or total hip replacement for displaced fractures in older, less active patients.
Okay, knee dislocations. They sound like an emergency.
They are a true orthopedic emergency. Knee dislocation, tibiofemoral dislocation, is rare but limb-threatening due to the extremely high risk of popliteal artery injury, up to 40–50% risk, and peroneal nerve injury. Urgent reduction is the priority, often done for extensive imaging. Post-reduction radiographs might show subtle residual signs like joint space incongruity, widening of one compartment, small avulsion fractures like the lateral capsular sign, second fracture indicating ACL tear, or osteochondral defects from the impact. Vascular assessment is paramount after reduction.
And tibial plateau fractures.
Tibial plateau fractures involve the articular surface of the proximal tibia, often caused by axial loading with a valgus or varus force. The Schatzker classification, types IZ, is commonly used to describe the pattern from simple lateral splits, type I, to complex bicondylar fractures with metaphyseal-diaphyseal dissociation, type PSIV. Standard AP and lateral views are essential, but oblique views, CT scans are often needed to fully appreciate the degree of articular depression and comminution, which dictates surgical management, often ORF.
Finally, ankles, especially those tricky syndesmotic injuries.
Yes, ankle fractures are common. Standard views are AP, lateral, and the crucial mortise view, AP with 15–20 degrees internal rotation. The mortise view profiles the talus within the articulation formed by the tibial plafond and the two malleoli. We look for fractures, obviously, but also subtle signs of instability, particularly involving the syndesmosis, the ligaments connecting the distal tibia and fibula. Radiographic signs of syndesmotic injury or instability include increased tibiofibular clear space, should be 6 millimeters on AP and mortise. Decreased tibiofibular overlap on the AP, should be 6 millimeters or 1 millimeters on mortise. Or an increased medial clear space between the talus and medial malleolus, should be A4 millimeters, roughly equal to superior clear space. Any widening suggests syndesmotic disruption, often requiring specific fixation. Syndesmotic screws.
Those measurements are key then. Spine trauma next. Always worrying due to potential neurological injury. What are the radiographing priorities for cervical and thoracolumbar spine injuries?
In cervical spine trauma, assessment often starts in A&E, potentially with an unconscious or uncooperative patient. The lateral view is the single most important initial film. It must adequately visualize all 7 cervical vertebrae down to the top of T1.
Seeing C71 is crucial.
Absolutely essential. On the lateral, we systematically assess alignment, looking for subluxation, using the 4 parallel lines: anterior vertebral line, posterior vertebral line, spinal laminar line, posterior spinous line, bone integrity fractures, cartilage, disc spaces, and soft tissues, prevertebral swelling. We look at the C1 arches, the odontoid process, and critically, the atlantoidens interval, ADI, the space between the back of the anterior arch of C1 and the front of the dens. 3 millimeters in adults, 5 millimeters in children, implies transverse ligament injury and instability. CT is now often the primary modality in significant trauma, but understanding the plain film findings remains vital.
And thoracolumbar.
For thoracolumbar spine trauma, we often use the 3-column model, Dennis classification, to conceptualize stability. The anterior column, anterior longitudinal ligament, anterior half of vertebral body disc, middle column, posterior half of body disc, posterior longitudinal ligament, and posterior column, pedicles, facets, lamina, spinous process, posterior ligaments. Injury to 2 or more columns implies instability. Radiographically, look for vertebral body height loss, compression fracture, widening of the interpedicular distance, suggesting a burst fracture with retropulsion into the canal, malalignment, paraspinal soft tissue swelling, hematoma, specific fracture patterns like the chance fracture, horizontal fracture through body, pedicles, and posterior elements, often a flexion distraction seatbelt injury, need recognition as they are highly unstable. Again, CT provides much more detail, especially for posterior element injuries and canal compromise.
The pelvis and sacroiliac region notoriously complex, high-energy injuries often. What specific radiographic views help us unravel those intricate fracture patterns and disruptions?
You're right, the pelvis and acetabulum are challenging. Standard AP pelvis view is just the starting point, especially in high-energy trauma. It gives an overview of the pelvic ring, but often hides detail, particularly in the acetabulum. For acetabular fractures, the Juda views are indispensable. These are oblique views. The iliac oblique view, patient rolled 45 degrees away from the injured side, profiles the posterior column and the anterior wall of the acetabulum. The obturator oblique view, patient rolled 45 degrees towards the injured side, profiles the anterior column and the posterior wall. Together, they give orthogonal views critical for classifying the fracture and planning surgery. For assessing pelvic ring stability, we add inlet and outlet views. The inlet view, beam-angled 40-60 degree caudal, looks down the barrel of the pelvic ring, thus showing anterior-posterior displacement or rotation of the sacroiliac joints or cubic symphysis. The outlet view, beam-angled 40-45 degree cephalad, looks up from below, best showing vertical displacement, vertical shear of the hemipelvis or sacral fractures. These views are essential for understanding pelvic ring instability.
And finally, rounding off trauma, let's talk pediatrics. How do children's bones fail differently, and what specific fracture types do we need to recognize radiographically given their growing skeletons?
Pediatric bones are fundamentally different. They're more porous, have thicker periosteum, and of course, active growth plates, physes. This means they respond to trauma differently than adult bones. Fractures often occur with lower energy. Specific patterns unique to children include buccal or torus fractures. These are compression failures, usually near the metaphysis, for example, distal radius. The cortex wrinkles or buckles outwards but doesn't break completely through. They are stable. Green stick fractures. An incomplete fracture where one side of the cortex breaks but the other side just bends, like breaking a young green twig. The intact cortex is under tension. These often need manipulation to complete the fracture for proper alignment and healing. Plastic deformation. The bone bends beyond its elastic limit and retains a deformed shape without a visible fracture line. Common in the ulna or fibula. It's essentially lots of microfractures, and crucially, physial injuries fractures involving the growth plate. These account for 15–30% of all childhood fractures. The Salter-Harris classification, types IV, is essential here.
Remind us of the basics of Salter-Harris.
Type 1 is straight across the physis. Often looks normal on X-ray, diagnosis based on tenderness. Type 2 goes across the physis and out through the metaphysis, most common type. Type 3 goes across the physis and out through the epiphysis into the joint. Type 4 goes through metaphysis, physis, and epiphysis. Type V is a crush injury to the physis, worst prognosis for growth disturbance. This is where comparison views of the uninjured side become so important, especially for subtle type 1 or 2 injuries, to differentiate a normal physis from a fracture. Always think Salter-Harris in a child with bony tenderness near a joint.
Right. Moving beyond trauma now, let's turn our attention to diagnosing disease processes. First up, arthritides, that huge category of joint abnormalities. How does conventional radiography serve as the cornerstone here, despite perhaps newer modalities being available?
Arthritis, in its broadest sense, degenerative, inflammatory, metabolic, etc., is primarily evaluated, at least initially, using conventional radiography. It remains the most significant single technique. As with trauma, we need at least 2 projections, 90 degrees apart. But crucially for arthritis assessment, especially in weight-bearing joints like the hips, knees, or ankles, weight-bearing views are often invaluable.
Why the emphasis on weight-bearing?
Because they provide a dynamic assessment. They show the true degree of joint space narrowing under physiological load. A non-weight-bearing view might make a severely worn joint look deceptively okay because the cartilage space opens up without load. Weight-bearing views give a much more accurate picture of functional cartilage loss.
Makes perfect sense. Let's focus on the most common type then, osteoarthritis, OA. What are those 4 cardinal radiographic signs of degenerative joint disease we should be looking for, particularly in the hip and knee? What story do they tell?
For osteoarthritis, or DJD, there are 4 key radiographic signs, and they tend to appear in a somewhat typical progression. Firstly, joint space narrowing. This reflects the loss or thinning of the articular cartilage. It's often asymmetrical, affecting the areas of highest load first, e.g., the superior aspect of the hip joint, or the medial compartment of the knee.
The cartilage wears away, the space gets smaller.
Exactly. Secondly, subchondral sclerosis. This is increased bone density in the bone immediately beneath the worn cartilage. It looks wider on the X-ray. It's the bone's reactive attempt to harden itself in response to the increased stress, sometimes called eburnation when it's very dense. Thirdly, osteophyte formation. These are bony spurs or outgrowths, typically forming at the joint margins in areas away from the main stress. They represent the bone's attempt to increase the joint surface area and perhaps stabilize it, though they can also cause mechanical impingement.
Marginal spurs.
Yes. And fourthly, subchondral cysts. These are lucent, cyst-like lesions within the subchondral bone, often seen in later stages. They're thought to be caused by synovial fluid being forced into the bone through microfractures, or from bone necrosis, also called geodes or eggers, cysts in the hip. In the knee, this pattern often leads to varus, bow-legged deformity if the medial compartment is worst affected, or valgus, knock-kneed, if the lateral side goes first. Weight-bearing views really highlight this. The ankle shows similar changes: joint space loss, sclerosis, osteophytes, maybe cysts and deformity.
That's a very clear picture of OA. How might inflammatory arthritis, like rheumatoid, present differently on a radiograph? What are the key differentiators we should look for?
Inflammatory arthrotypes, like rheumatoid arthritis, RA, or psoriatic arthritis, have distinct radiographic features that usually allow differentiation from OA, especially earlier in the disease course. While both cause joint space narrowing eventually, inflammatory arthritis typically shows. Early juxta-articular osteopenia bone around the joint looks less dense due to increased blood flow and inflammation. OA tends to have normal or increased density sclerosis. The hallmark is erosions. These are discrete areas of bone destruction, often starting at the bare areas within the joint where synovium contacts bone directly or at the joint margins. They look like little scooped-out defects. OA tends to form bone osteophytes rather than erode it, though erosive OA is a subtype.
So OA builds bone spurs, RA eats away at bone.
That's a useful simplification, yes. Also, the distribution is different. OA often affects large, weight-bearing joints or specific small joints, like finger DIPs. RA typically affects small joints of the hands and feet symmetrically, MCPs, PIPs, wrists, though it can affect larger joints too. You might also see uniform joint space narrowing as the whole cartilage layer is attacked, rather than the focal narrowing of OA, and sometimes soft tissue swelling due to synovitis or late-stage deformities like subluxations, for example, ulnar deviation in the hand. Now, moving to a more daunting area, bone tumors. How does conventional radiography as our first-line investigation provide such critical initial information in orthopedic oncology? It seems to do a lot of the heavy lifting before we get to biopsy or advanced scans. It absolutely does. Plain radiography is remarkably powerful as the initial tool in orthopedic oncology. It provides foundational information that really sets the diagnostic pathway. It tells us the patient's precise location within the bone epiphysis, metaphysis, diaphysis, central or eccentric, which specific bone. That alone narrows the possibilities, hugely based on typical tumor locations for different age groups. It shows the lesion's shape and size, but more importantly, it gives vital clues about its biological activity based on the type of bone damage it's causing. Is it destroying bone, phylitic, forming bone, sclerotic blastic, or a mix? We also look carefully at the margins of the lesion. Are they sharp and well-defined, or wide and infiltrative? Does it contain calcifications or ossifications of the matrix? And critically, what is the peripheral reaction? How is the bone's outer layer responding?
So you're building a profile of the lesion's behavior.
Exactly. When you combine these radiographic features with essential clinical data, the patient's age, perhaps the single most important factor, duration of symptoms, speed of growth, plain films, frequently allow us to generate a very focused differential diagnosis. Often, we can make a highly probable diagnosis, or at least confidently distinguish between likely benign and likely malignant processes, guiding the need for further imaging, like MRI for staging, or the type and urgency of biopsy. It's indispensable for that initial characterization.
Fascinating. It really is like reading a forensic report written in bone. What are those critical radiographic features in detail, the code we need to crack when evaluating a tumor or tumor-like lesion?
It is a bit like cracking a code. There are several key features we systematically assess, each providing a vital clue. First, as mentioned, lesion location. Specific bone and site within the bone. Epiphysis, metaphysis, diaphysis. Central, eccentric, cortical, medullary. Age plus location equals narrow differential. Second, lesion border zone of transition. This reflects the growth rate. A narrow zone, sharp, well-defined border, maybe with a sclerotic rim, suggests slow growth, likely benign. A wide zone, indistinct fuzzy border, blending into normal bone, implies rapid infiltrative growth, likely malignant.
Sharp is good, fuzzy is bad, generally speaking.
Generally, yes. Third, type of bone destruction. Geographic. Large, well-defined holes, often lobulated. Subtypes based on margin. Sclerotic, non-sclerotic, ill-defined. Usually slower growing, moth-eaten. Multiple smaller coalescing holes with poorly defined edges. More aggressive. Permeative. Numerous tiny pinprick holes diffusely infiltrating the bone, very aggressive, associated with round cell tumors like Ewing's or myeloma or infection. Fourth, type of matrix. What's inside the lesion? Is it purely elytic, black? Does it contain calcification, punctate rings, arcs suggesting cartilage, or ossification, fluffy, cloud-like, dense suggesting bone formation, or ground glass, fibrous dysplasia?
Clues about the tissue type.
Precisely. Fifth, periosteal reaction. How the outer bone layer, periosteum, reacts to the lesion. Benign reactions are typically solid, thick, uniform, or undulating, sometimes just cortical thickening. Indicates slow irritation. Aggressive reactions are interrupted, complex. Classic patterns include lamellated, onion skin layers of new bone, spiculated, hair on end or sunburst radiating spicules, or a Codman triangle, periosteum lifted off the bone at the edge of a rapidly growing lesion. These signal malignancy or infection. And sixth, soft tissue extension. Is there evidence of the lesion breaking out of the bone into the surrounding soft tissues? A definite soft tissue mass is a strong indicator of malignancy.
That's a very detailed checklist. Based on these criteria, can you give us some quick distinguishing features? How do we start to differentiate between likely benign, likely malignant, and maybe specifically cartilage tumors just from the radiograph?
Certainly. These are general rules of thumb. Combine those features. Likely benign tumor indicators. Often geographic bone destruction with a narrow zone of transition, frequently with a sclerotic rim. Usually a solid, uninterrupted periosteal reaction, or often no periosteal reaction at all. Generally, no associated soft tissue mass. Examples: simple bone cyst, non-ossifying fibroma, osteoid osteoma, though this has specific features like anitis, likely malignant tumor indicators. Typically poorly defined margins with a wide zone of transition, often moth-eaten or permeative bone destruction. An interrupted aggressive periosteal reaction, sunburst, onion skin, Codman triangle, crucially often evidence of a soft tissue mass. Examples: osteosarcoma, Ewing sarcoma, chondrosarcoma, high-grade metastases. Cartilage tumor indicators, benign or malignant, often show lobulated shapes, potentially causing endosteel scalloping, indentation of the inner cortex. The key is the matrix. Characteristic punctate, rings, and arcs, or comma-like calcifications. This chondroid matrix is highly suggestive. Examples: enchondroma benign, osteochondroma benign surface lesion, chondrosarcoma malignant. Differentiating benign from low-grade malignant cartilage tumors radiographically can be very tricky.
Let's illustrate with a few key examples. What do we typically see radiographically with a giant cell tumor, GCT? And how does that differ from, say, a highly aggressive osteosarcoma? They both affect bone, but tell such different stories on film.
Right, good examples showing different patterns. A giant cell tumor, GCT or osteoclastoma, is technically benign, but can be locally aggressive and metastasize rarely. Radiographically, it's typically a purely osteolytic, lucent lesion, often eccentric in location, frequently causing expansile remodeling, ballooning of the bone. Crucially, it occurs almost exclusively at the epiphysis or epiphyseal equivalent, like the apophysis of the calcaneus, of a long bone after physeal closure. Skeletally mature patients, usually 20–40 years old. Location is key. The margin is usually well-defined but non-sclerotic, meaning a narrow zone of transition, but without that reactive white line. Periosteal reaction is usually absent unless there's a pathological fracture through it.
So an epiphyseal bubble in a young adult.
That's a good image for it. In stark contrast, osteosarcoma, the most common primary malignant bone tumor, excluding myeloma lymphoma, typically arises in the metaphysis of long bones, especially around the knee, distal femur, proximal tibia, usually in adolescents or young adults, though a second peak occurs in the elderly, often secondary to Paget's disease. Radiographic hallmarks are signs of aggressive bone destruction, often moth-eaten or permeative, with a wide zone of transition. Crucially, it produces bone, osteoid matrix, so you often see fluffy, cloud-like, or dense tumor bone within the lesion or in the soft tissue mass. Aggressive periosteal reaction is very common, classic sunburst spiculation or a Codman triangle. A large soft tissue mass is frequently present. It looks chaotic, destructive, and infiltrative.
Very different picture indeed. How about Ewing sarcoma and multiple myeloma? They also have quite distinct radiographic features, often affecting different age groups too.
Absolutely. Distinct patterns again. Ewing sarcoma is another highly aggressive malignancy, typically affecting children and young adults, peak 10–20 years. It's a small, round, blue cell tumor. Commonly arises in the diaphysis shaft of long bones, femur, tibia, humerus, or flat bones like the pelvis or ribs. Radiographically, it causes permeative or moth-eaten bone destruction with a very wide zone of transition, often looking like the bone is just fading away. A large, soft tissue mass is often disproportionately prominent compared to the visible bone destruction. The classic periosteal reaction is lamellated, onion skin, though sunburst or Codman triangles can also occur. It looks very aggressive and infiltrative.
Permeative description, onion skin periosteum, large, soft tissue mass in a young person. Think Ewing's.
That's the pattern. Multiple myeloma, on the other hand, is the most common primary malignant bone tumor overall, but it's a disease of plasma cells in the bone marrow, typically affecting older adults, peak 50-70 years. Classic appearance is multiple, discrete, well-defined, purely lytic, punched-out lesions, often relatively uniform in size. Crucially, these lesions typically lack a sclerotic rim, just holes. They are widely distributed, particularly favoring the skull, spine, ribs, pelvis, femora, humerus areas with active red marrow. Sometimes it presents as diffuse osteopenia, or less commonly, a single large lesion, plasmacytoma. Pathological fractures are common. The lack of reactive sclerosis around the warrenellitic lesions is a key feature, differentiating it from many metastases.
Punched out holes, no sclerosis, older adult. Think myeloma.
That's the classic triad, yes.
Finally, Professor, on metastatic bone tumors, how do they compare in frequency to primary bone tumors, and what are the challenges in detecting them radiographically, especially early on? Often we find them met first and then hunt for the primary.
That's a critical point. Skeletal metastases from carcinomas, like breast, lung, prostate, kidney, thyroid, are vastly more common than primary bone tumors in adults, by a huge margin. They typically reach the bone via the bloodstream and set up shop. Most metastases destroy bone, resulting in lytic lesions. Common primaries causing lytic emets include lung, kidney, thyroid, and most breast cancers. However, some primaries characteristically promote bone formation, resulting in sclerotic or blastic lesions, dense white spots. Prostate cancer is the classic example, but some breast cancers can also be sclerotic, as can carcinoid or medulloblastoma less commonly. Some mets are mystolytic and sclerotic.
So mets can look lytic, sclerotic, or mixed.
Exactly. The main challenge in radiographic detection, especially for leukemic mets, is sensitivity. A metastatic deposit generally needs to destroy 30% to 50% of the trabecular bone in a given area, or erode the cortex before it becomes reliably visible on a plain radiograph.
So a lot of damage can happen before we see it on X-ray.
Yes. Small lesions, especially in the spine or pelvis where there's a lot of overlying structure, can be easily missed. This is why radionuclide bone scans, technetium-99 m MDP, are much more sensitive for detecting early or widespread metastatic disease. They detect the increased bone turnover around the lesion, often long before enough bone is destroyed to be seen on X-ray. Plain films are better for characterizing a known lesion, catalytic for sclerotic, risk of fracture, but less sensitive for initial screening compared to a bone scan or sometimes MRI, PET, CT.
Let's transition now to infections, osteomyelitis, septic arthritis, another critical area where radiography plays a vital role, although perhaps with some delay compared to clinical signs. What are the earliest radiographic indicators of bone infection, osteomyelitis, and how do they progress?
You're right, there's often a lag. Musculoskeletal infections, bone, osteomyelitis, joint septic arthritis, soft tissue, cellulitis can be devastating. Radiography is key, but the changes take time to appear. For pyogenic osteomyelitis, bacterial bone infection, the radiographic signs progress chronologically. In the very early stages, first 24 or 48 hours, maybe up to a week, plain films are often completely normal or may show only subtle, nonspecific soft tissue swelling and perhaps loss of the normal fat planes next to the bone. Very easy to miss. MRI or a bone scan would be positive much earlier.
So a normal X-ray doesn't rule out early osteomyelitis.
Absolutely not. By about 7 to 10 days, you might start to see the first subtle signs of bone involvement. Perhaps focal osteopenia, demineralization in the affected area, or the very beginning of a destructive lytic lesion. In the intermediate stage, say 2 to 6 weeks, the changes become more obvious. You see progressive cortical and medullary bone destruction, looks like irregular holes or erosion, along with the bone's reactive response. Periosteel reaction, new bone forming on the outer surface, often initially thin and lamellated, and maybe some surrounding sclerosis.
Bone starts reacting to the infection.
Yes. Finally, in the chronic stage, typically after 6 to 8 weeks but can be months, the classic features of chronic osteomyelitis emerge. Formation of sequestra. These are fragments of dead necrotic bone that become isolated within the infected area. Because they've lost blood supply, they often appear relatively denser than the surrounding demineralized infected bone. And surrounding the sequestra, you often see a thick sheath of reactive new bone called the involucrum, formed by the elevated periosteum trying to wall off the infection. Sometimes there are openings in the involucrum called clecae, allowing pus to drain. Sequestra plus involucrum equals chronic osteomyelitis.
That's a clear progression from subtle soft tissue signs to frank bone destruction and sequestra. What about infection within the joint septic arthritis? What do we look for there, from early clues to late-stage damage?
Septic arthritis is a true orthopedic emergency. because bacterial enzymes can destroy articular cartilage very rapidly within days. Usually affects a single joint, often knee or hip. Early radiographic signs are again often nonspecific and lag behind clinical symptoms. Joint effusion. Fluid distending the joint capsules, often the first sign. Joint effusion. Soft tissue swelling around the joint. Periarticular osteopenia. Demineralization of bone adjacent to the joint due to hyperemia, increased blood flow, and disuse from pain. Periarticular osteopenia. Crucially, in the initial stages, first few days, the joint space itself is typically preserved. The cartilage hasn't been destroyed yet.
So joint space preservation early on doesn't mean it's not septic arthritis.
Correct. Diagnosis relies on joint aspiration. In later stages, however, if treatment is delayed or ineffective, the infection leads to rapid articular cartilage destruction. Radiographically, this manifests as rapid and often uniform narrowing of the joint space. Unlike OA, which is often focal, infection tends to destroy cartilage globally. You may also see erosions and destruction of the subchondral bone on both sides of the joint. It's a much more aggressive and rapid joint destruction pattern than OA.
Tuberculosis of the spine, pot spine, that's a specific entity. How does it manifest radiographically? And does TB affect peripheral joints differently?
Tuberculosis of the spine, POTS disease, is a chronic granulomatous infection caused by Mycobacterium tuberculosis. It typically affects the anterior aspect of the vertebral bodies and the intervertebral discs. Radiographic hallmarks often include slowly progressive narrowing of a disc space, often affecting multiple contiguous levels, destruction and erosion of the adjacent vertebral end plates, initially often appearing fuzzy or indistinct. As it progresses, vertebral body collapse can occur, leading to anterior wedging and eventually a significant angular kyphosis, known as a gibbous deformity. A large paraspinal soft tissue mass, representing a cold abscess, pus without acute inflammation, is very common and characteristic. It might track along tissue planes. Occasionally, TB can affect posterior elements or a single vertebra without disc involvement.
So disc space narrowing, end plate destruction, potential gibbous, and that paraspinal shadow.
That's the classic picture. For peripheral joint tuberculosis, it typically presents as a chronic, indolent monoarticular arthritis, affecting a single joint. The radiographic findings develop slowly and are captured by the Phemister triad: periarticular osteoporosis, often marked; peripheral osseous erosions, often starting at the joint margins; gradual narrowing of the joint space, slower than pyogenic septic arthritis. This slow, destructive pattern in a single joint should raise suspicion for TB, especially in endemic areas or immunocompromised patients.
Right, let's shift focus now to systemic conditions that impact the skeleton, metabolic, endocrine, developmental disorders. How reliable is plain radiography for assessing something like overall bone density? What are its limitations and those crucial technical factors we need to keep in mind?
Well, plain radiography is certainly the simplest and most widely available method for qualitatively assessing bone density, but it has significant limitations that we absolutely must remember. Its main drawback is its insensitivity. It generally fails to detect overall losses in skeletal mineralization unless the reduction is quite substantial, typically estimated at more than 30% to 50%.
So by the time you clearly see it on an X-ray, a lot of bone has already been lost.
Precisely. The disease process, like osteoporosis, is often well advanced by the time it's obvious on plain film. This is why quantitative methods like DEXA, dual energy X-ray absorptiometry scans, are the gold standard for diagnosing and monitoring osteoporosis. They are far more sensitive and precise. Furthermore, technical factors during image acquisition can massively influence the apparent density. Overexposure, too dark a film, or processed too brightly digitally, can artificially make normal bone look radiolucent, mimicking osteopenia. Underexposure can make osteopenic bone look falsely normal or even dense.
So technique consistency is vital.
Absolutely. So while plain film can flag severe cases, show relative changes over time, or reveal complications like fractures, it's not a reliable quantitative tool for bone density measurement itself. Always interpret density findings with caution and consider the technique.
That's a really crucial point. Now, can you clarify the terminology? We often hear osteopenia, osteoporosis, osteomalacia used, sometimes interchangeably. How do they differ fundamentally, and how does the balance of bone formation versus resorption relate to how they look on X-ray?
It's vital to differentiate these terms. They describe distinct pathologies, even if they all might result in bones looking less dense on X-ray. Osteopenia is purely a radiographic descriptive term. It simply means poverty of bone. The bone appears more radiolucent than expected on the X-ray. It doesn't specify the underlying cause. It's an observation, not a diagnosis in itself.
Just means looks thin.
Exactly. Osteoporosis, however, is a specific metabolic bone disease. It's defined by decreased bone mass and microstructural deterioration of bone tissue. The key is a quantitative deficiency. There's simply less bone matrix present, but the bone that is there is normally mineralized. Think of it like having fewer, thinner struts in a scaffold, making it weaker. It results from an imbalance where bone resorption, breakdown by osteoclasts, outpaces bone formation, building by osteoblasts.
Less bone, but properly hardened bone.
Correct. Osteomalacia in adults and its childhood equivalent rickets represent a qualitative defect. Here, there is defective mineralization of the bone matrix. Bone matrix is being produced, but it fails to calcify properly due to insufficient calcium, phosphate, or vitamin D activity.
Yeah.
So you have adequate or even increased amounts of unmineralized matrix, osteoid. The bone is soft, not properly hardened.
Enough bone matrix, but it's soft.
That's the core difference. Radiographically, both osteoporosis and osteomalacia rickets will appear as osteopenia, increased radiolucency, because both conditions result in less mineral content per unit volume of bone for the X-rays to be absorbed by. But the underlying pathology, and thus other associated radiographic signs and treatment, are quite different. An imbalance towards resorption leads towards osteoporosis. An imbalance in mineralization leads towards osteomalacia or rickets.
That clarifies things beautifully. Now, what are the specific distinct radiographic features of rickets in children and osteomalacia in adults? How do they manifest differently on film, reflecting that defective mineralization?
For rickets in children, because it affects actively growing bone, the radiographic features are most striking at the metaphyses and epiphyses, the zones of rapid growth. We see widespread skeletal demineralization, often leading to bowing deformities in weight-bearing bones, legs. The hallmark sign is changes at the growth plate, physis, widening of the physeal plate due to accumulation of unmineralized cartilage, and cupping, fraying, and irregularity of the adjacent metaphysis. It looks disordered, indistinct, sometimes described as brush-like. The hallmark sign is changes at the growth plate, physis. The secondary ossification centers, epiphyses, may also appear poorly defined, indistinct, and radiolucent, losing their sharp margins. It looks like the bone ends are soft and splayed out.
Very characteristic changes at the growth zones, then.
Yes. In osteomalacia in adults where growth plates have closed, the presentation is different, you see. Generalized osteopenia making the bones look washed out, often with thinning of the cortices and indistinct trabeculae. But the most distinctive and diagnostically crucial feature is the presence of pseudofractures, also known as looser zones.
Ah, looser zones. What are they exactly?
There are short radiolucent lines, usually running perpendicular to the cortex, often bilateral and symmetric. They represent bands of unmineralized osteoid that have formed at sites of stress concentration, essentially, cortical insufficiency stress fractures that haven't mineralized properly. They are commonly seen along the axillary borders of the scapulae, the inner compressive side of the femoral neck, the pubic rami, ribs, and proximal ulae. Finding these looser zones is highly suggestive, almost pathognomonic, of osteomalacia.
What about hyperparathyroidism? How does this endocrine disorder with its excessive parathyroid hormone leave its mark on the skeleton radiographically? It can be subtle initially, can't it?
It can be subtle, yes, but it produces quite characteristic features due to PTH-stimulating osteoclast activity and thus bone resorption. Radiographically, we look for generalized osteopenia is common, reflecting overall bone loss, but the most specific and virtually diagnostic finding is subperiosteal bone resorption. This is bone loss occurring directly underneath the periosteum. The classic location to look for this is on the radial aspects of the middle phalanges of the index and middle fingers. You see an irregular, lacy, or eroded appearance of the cortical surface. The fingers are key then. Absolutely key for that sign. You can also see resorption elsewhere. Subchondral, beneath cartilage, leading to joint space widening initially. Intracortical, creating tunnels within the cortex. Endosteal, and even subligamentous resorption. Brown tumors. These are not true tumors, but focal collections of osteoclasts, fibrous tissue, and hemorrhage resulting from excessive resorption. They appear as well-defined expansile lytic lesions, commonly in the jaw, epulus, pelvis, ribs, or long bones. Brown tumors, loss of the lamina dura around the teeth. Brown tumors. In severe chronic cases, often secondary hyperparathyroidism and renal failure, you can see generalized changes termed osteitis, fibrosis cystica, and sometimes soft tissue or vascular calcification due to calcium phosphate imbalance. But that subperiosteal resorption of the phalanges is the earliest and most specific sign.
Finally, Professor, let's briefly touch upon congenital and developmental skeletal disorders. How do these variations in skeletal form and function manifest radiographically? What's important for their assessment, perhaps particularly for pediatric clinicians?
Congenital and developmental disorders encompass a vast and fascinating range of skeletal anomalies present from birth or arising during growth. Radiography is key to identifying and characterizing them. They broadly fall into categories like anomalies of formation, where bones fail to form correctly or segment properly. Examples include segmentation failures like synostosis, abnormal fusion, example, radioulnar synostosis limiting forearm rotation, or syndactylly fused digits. Or formation failures like congenital pseudoarthrosis, a false joint where a bone fails to unite, classically in the tibia. Anomalies of size or shape, resulting from disrupted growth patterns. This could be undergrowth, hypoplasia, plasia, bone being too small or absent, or overgrowth, hypertrophy gigantism, or distorted growth leading to abnormal shapes like congenital tibia vara, Blount's disease, severe bowing, or Madelon deformity of the wrist, abnormal distal radial growth.
So bones too small, too big, fused, or misshapen.
Exactly. And anomalies affecting joint motion, due to abnormal joint development leading to instability or restricted movement. Classic examples include developmental dysplasia of the hip, DDH, ranging from mild acetabular shallowness to complete dislocation, or congenital talipes equinovarus, clubfoot, a complex foot deformity. For radiographic assessment, standard AP and lateral views are usually the starting point. Comparison views of the contralateral side can be helpful, especially if asymmetry is suspected. Specific views might be needed for certain conditions. For example, specific hip views for DDH assessment using lines like Perkins, Hilgenreiner's, Shenton's, weight-bearing views of the feet for clubfoot evaluation. The key is often comparing the findings to establish norms for the patient's age and recognizing deviations from expected developmental milestones and anatomical relationships. It requires a good understanding of skeletal development.
Right. Our clinical responsibility doesn't end with the surgery, does it? It just enters a new phase of radiographic surveillance. What are the most common implant-related complications we should be looking for postoperatively? And critically, how do they actually appear on film, giving us those hints of trouble?
You're absolutely right. Post-operative radiographic follow-up is critical for monitoring the success of orthopedic interventions and catching complications early. We vigilantly look for several common issues related to implants. Firstly, loosening. This is where the implant, screws, plates, joint replacement components, loses its stable fixation to the bone. Radiographically, the key sign is the development or progression of a radiolucent line or gap at the bone-implant interface, typically defined as being 2 millimeters or wider. You might also see a change in the implant's position or angle compared to previous films, or migration of the component.
That gap is the main sign.
It's a very important sign, yes. It can be caused by mechanical failure, poor initial fixation, poor bone quality, osteoporosis, excessive stress, or underlying infection, septic loosening. An example might be loosening of plate and screw with peri-implant osteolysis and non-union, a triple whammy indicating fixation failure, bone loss around the implant, and the original fracture not healing. Usually requires revision surgery. Secondly, infection. Implant-associated infection is a serious complication. Radiographic signs often lag behind clinical symptoms and can be subtle or indirect. Look for persistent or new soft tissue swelling, development of a periosteal reaction along the bone near the implant, which should normally be there long after surgery unless there's loosening or infection. Progressive osteolysis, bone destruction around the implant that looks irregular or poorly defined, or sometimes visible sinus tracts or abscess collections if contrast is used. Differentiating septic from aseptic mechanical loosening radiographically can be very difficult.
So infection signs can be quite subtle on X-ray.
They can be. Thirdly, fracture or breakage of the implant itself. Hard work can fail due to material fatigue, excessive load, or poor design. Radiographs will clearly show a discontinuity in the implant, a broken plate, a fractured intramedullary nail stem, broken screws. This category also includes peri-implant fractures. This is a fracture of the bone around an existing implant, often occurring at the tip of a plate or stem where stress concentrates. The fracture line relative to the implant will be clearly visible. These often require complex revision surgery.
Malalignment.
Fourthly, malalignment or malpositioning. This refers to incorrect placement of the implant during the initial surgery. Radiographs will reveal the implant's improper position or angle relative to anatomical landmarks or the desired alignment. This can lead to pain, instability, functional limitation, or accelerated wear. Fifthly, allergic reactions to implant materials like nickel, cobalt, chromium. Rare but can cause chronic pain, swelling, effusion, and sometimes radiographic signs like localized osteolysis or synovitis around the implant, though often the x-rays are nonspecific.
And finally, wear and tear.
Yes, particularly relevant for joint replacements. Over time, the bearing surfaces, commonly polyethylene liners in hips and knees, can wear down. This releases microscopic wear particles. Radiographically, wear itself might be seen as progressive narrowing of the joint space between the metal or ceramic components, or migration subsidence of components. Critically, the wear particles can trigger an inflammatory response leading to osteolysis bone loss around the implant, often appearing as scalloped lucencies, especially around screws or at the margins of cemented components. This is often termed particle disease or aseptic loosening. An example might be aseptic osteolysis and implant loosening in a hip replacement, potentially leading to component migration, like protrusio acetabuli, where the cup moves immediately into the pelvis. So, regular radiographic follow-up is essential to monitor for all these potential issues.
Absolutely. Vigilance after intervention is clearly paramount. Let's conclude then by looking at how radiography validates the success of reconstructive procedures themselves. Can you briefly outline the types of implants used in fracture fixation and joint replacement, and how we use x-rays to confirm their integrity and ultimately the success of the repair? It's about seeing that blueprint of healing and restoration, isn't it?
It is indeed. Radiography is our primary tool for confirming that reconstructive procedures have achieved their goal and that the construct remains sound over time. For fracture fixation implants, we use various devices depending on the fracture type and location. Screws, used alone for certain fractures, example malleolar fractures, scaphoid fixation, or more commonly with plates or nails. Radiographs confirm good thread purchase in bone, appropriate length, not penetrating joints or irritating soft tissues, and compression across the fracture line if intended. Examples: cortical screws, cancellous screws, cannulated screws. Plates, rigid metal plates held by screws used to bridge and stabilize fractures, especially comminuted or periarticular ones. Radiographs check for good plate contouring to the bone, adequate screw placement on both sides of the fracture, fracture reduction, and alignment. Examples: dynamic compression plates, DCP, locking compression plates, LCP, specific anatomical plates, for example, distal radius plate, intramedullary nails, inserted down the medullary canal of long bones, femur, tibia, humerus, for stable fixation, often allowing early weight bearing. Radiographs confirm correct entry point, nail length and diameter, fracture reduction, and placement of interlocking screws, proximally and distally, to control length and rotation. Examples: proximal femoral nail, anti-rotation, PFNA, tibial interlocking nail, external fixators, pins or wires inserted into bone and connected to an external frame. Radiographs monitor fracture alignment, check for pin loosening, radiolucency around pins, pin site infection signs, and assess healing progress before removal.
So, checking position, alignment, reduction for fracture fixation. What about joint replacements?
For joint replacement implants, arthroplasty, radiography is key for assessing initial placement and long-term performance. Total joint replacement, TJR. Replacing the entire joint, either hip, knee, shoulder, elbow. Radiographs confirm component positioning, for example, stem alignment, cup inclination, aberration in hips, femoral tibial component alignment, patellar tracking in knees, appropriate sizing, restoration of joint line, and limb length offset. We also assess the cement mantle if cemented components are used, or look for signs of stable osseointegration if cementless. Examples: total hip replacement, THR, total knee replacement, TKR, partial joint replacement, replacing only the damaged part. Examples include unicompartmental knee replacement, UKR medial or lateral compartment only, or arthroplasty for the hip, replacing only the femoral head, often for femoral neck fractures in the elderly. Radiographs check component position and articulation with the remaining native joint. Reverse, total shoulder replacement, used for rotator cuff deficient shoulders, reverses the normal ball and socket anatomy. Radiographs confirm the specific component placement and stability. Resurfacing arthroplasty, capping the joint surfaces, most commonly hip resurfacing. Radiographs check the position and fixation of the femoral head cap and acetabular cup. In all these cases, the post-operative radiograph serves as the baseline. Subsequent films are compared to this baseline to assess for fracture healing, if applicable, maintenance of alignment, and to screen for those complications we discussed: loosening, wear, osteolysis, infection, periprosthetic fracture. It provides that crucial visual confirmation that the reconstruction is stable, functional, and achieving its aim of restoring quality of life. We follow up united fractures fixed with plates, or check the alignment of spinal stabilization with pedicle screws, ensuring everything looks solid and well-positioned. It's a continuous visual dialogue. #outro.
What an absolutely illuminating journey through the world of musculoskeletal radiology. It really underscores that reading a radiograph is so much more than just spotting a line or a shadow, isn't it? It's about that systematic approach, understanding the subtle nuances of pathology, trauma, healing, appreciating the incredible stories these images tell. It's a language of light and shadow, telling tales of injury, disease, and remarkable recovery.
Indeed. The plain radiograph, seemingly simple, remains an unparalleled clinical compass in our field. It demands precision, certainly, experience helps, but also that holistic understanding of how bone and joints respond to stress, injury, and disease. Those fundamental principles we've discussed, they'll always remain paramount, even as newer imaging modalities continue to evolve. The basics provide the essential foundation for everything else.
And for us as clinicians, honing our ability to interpret these images with skill and confidence directly impacts patient care every single day. This deeper understanding empowers us to make more informed decisions, often faster, and ultimately to offer the best possible outcomes for the people we treat. It really is about becoming truly proficient in this silent, powerful language. If you found this deep dive valuable, please do consider taking just a moment to rate and share our deep dive with a colleague who might also benefit from these insights. A huge thank you to our expert guest today for such exceptional guidance and clarity. And to you, our dedicated listener, thank you for joining us on the deep dive. Keep sharpening that clinical eye, keep questioning the image, and we look forward to our next exploration together.